Hello, my name is Cameron MacDonald. Just a brief overview of some research we did during somewhat the height of the COVID epidemic in 2020. We wanted to look at the impact of the COVID epidemic in terms of the utilization of hands-on approaches in physiotherapist practice, and also how this was influencing education. Myself, I've been researching some of the historical aspects of how my PhD work with the historical genesis of manual therapy. We also have some research lines in dry needle and OMPT orthopedic practice and education and PT for physical therapists as well. We took some input from 22 different unique educators and practitioners around the world. We really tried to get a very global perspective, especially with touch points and some key decision makers in each of the countries represented, and also into standards that were being utilized. So the first was the 56 rule, basically that 56% of people were in outpatient practice, 56% were addressing the thoracic pain as a means to try and provide benefit to individuals who were being impaired by COVID at that time. 56% had a high impact of COVID at the time of reporting, but 56% of the PTs are not really able, all the decision makers and academic leads or clinical leads are not able to make any influence or determination of how they practice in terms of their use of hands-on care as a clinician at that time during the COVID epidemic. Well, perspectives on the care decisions though, 64% didn't feel what was happening was optimal, but a better decision could have been made based upon the context of in their particular occasion. Just under half thought they'd been over-distanced from their ability to care for patients by the regulations or procedures put in place, and less than 30% of clinicians were the ones actually making decisions about how they went about care delivery in terms of being hands-on or not. The decision-making processes that sort of influenced how they might go about doing hands-on care. It was cough screening, exposure to other people who are being exposed to COVID-19. You can see that list as it is in there. Patient preference was on that list, but further down, on fourth, fifth from the bottom. And there was just generally a huge array of options being presented. And we did ask the question, did the individuals feel that access to OMPT skilled care could improve the immune response of the individual? 36% said yes, maybe 32% no, and the rest were unsure. So a different story, it was like the risk benefit for clinical decision making around the use of OMPT care. 84% of providers didn't have anything really available to them to make that risk benefit analysis. 84% were using telehealth. So we proposed a risk benefit analysis tool, which is shown here on the screen. And on the left, under the yellow, potential benefit is there for manual therapy and options, maybe thoracic initially, joint and tissue after that. Otherwise, more of a telehealth path at that time. And finally, some educational activities in real brief. There's a lot more detail in the paper, which was linked on the first slide. But there's a 50 split at that time on whether the education should expectations and outcomes should change. The majority were like, only for now, once COVID has moved past that, we'll return to prior methods, and that may have occurred in many places. But there was a slight majority, though, who felt that there were some benefits that were accrued, that we learned to use Zoom, we learned to use mock patients, we learned to use video feedback, and we learned to use asynchronous options, very much technology-based, to evaluate the learning of individuals, and that was beneficial, and that will be carried forward going ahead. So thank you for your interest in the paper, the work of all the co-authors as listed, and we'll interesting to see what comes next.